morning. Over the past 2 decades, we have seen that awareness about ACL injuries has increased. Number of ACL reconstructions have shown a tremendous increase in their numbers, but exponentially we have seen an increase in ACL surgery failures, and therefore we are now experiencing a situation where we have also seen an increase in revision surgeries. In our own experience, we used to do about 3 revisions in a year, and today we do about 3 to 5 every month. So you can see that revision ACLs have increased, and one needs to be aware of the various challenges that are posed during revising ACL surgery. Now, failed ACLs account from anywhere from 3 to 25%, and these could be bone, patellar tendon bone or hamstring failures. When we talk about failure, it's not just a recurrence of the slack ACL or pseudo laxity of the ACL that patients present to us. The presentation of a failed ACL could also be from the point of view of restricted range of motion. A patient undergoes an ACL reconstruction, comes to you with a painful swollen knee, he has a restricted range of motion, he has continued pain, and this unsatisfactory outcome may be labeled in some cases as a failure of your ACL reconstruction. This is an example of a similarly failed ACL. This patient had undergone a hamstring ACL reconstruction. You can see that he has developed significant amount of arthrofibrosis. His patella is adherent. His range of motion, he has a fixed flexion deformity, and his range of motion is only up to about 80. And you can see that lack of extension can be significantly disabling functionally for any of these patients, and you need to address these issues. So more than flexion, extension can be significantly functionally disabling. ACL failures can be classified as early or late. Early are those within the first few months of an ACL reconstruction, and these are commonly because of graft related failures. So you could have poor fixation, graft laceration, incorrect tunneling, improper fixation, or missed lesions. And late failures are probably because of re-injury, either aggressive rehab or a re-injury after complete rehabilitation after an ACL. So failed ACLs could be because of surgical errors, it could be because of re-injury or biological failure. We need to realize that almost 60 to 70% of all failed ACLs are because of surgical errors, and these could start right from your graft harvest, where you have a thin, short, small, lacerated graft with not enough bone plugs if you are using a bone patellar tendon bone, to passage of graft to fixation of grafts. What is, however, very important is malpositioning of the ACL tunnels, and this accounts for a large number of ACL failures. The commonest mistake is anterior placement on the femoral tunnel, and as we all know, femoral malpositioning of the ACL leads to maximum number of failures. But you could also have malpositioning on the tibial side as well, and this could lead to impingement of the graft in the intercondylar area or the notch. So you could have graft failures because of impingement, too medial placement, as well as too much of a lateral placement of the graft, and hence tunnel positioning is extremely important to prevent graft failure. Graft impingement could also occur because of inadequate clearance in the notch, and when you are operating on a chronically unstable knee where the notch is stenotic, one may have to do a notchplasty in these situations to avoid graft impingement and eventual failure. Graft fixation, poor graft fixation can lead to day 1 failure of the graft. So if the graft is fixed in a slackened position, you can have a day 1 failure. Over constraining the graft is possible when you are using the bone patellar tendon bone, and this can lead to a captured knee with significant loss of motion. When you use interference screw, one needs to be aware of divergence of the screw, which may lead to poor fixation. And one should not compromise on the quality of fixators that you use, because your fixation device would lead to failure of fixation device could lead to failure of the graft on day one. One of the major reasons we have seen for ACL failure is, of course, overlooking associated laxities are associated with an ACL tear, and the commonly associated lesions are the posterolateral corner. The PCL, we have seen that in our patient population where ACL insufficiencies are commonly because of road traffic accidents, it is not unusual to have a bicruciate injury where the surgeon is so focused on the ACL that he addresses the ACL but overlooks the PCL. And we have found that failed ACLs are very often because of overlooking the posterior cruciate ligament. The posteromedial corner should also not be overlooked. You can have ramp lesions, you can have laxity of the posteromedial corner, which should not be overlooked. So associated PLC laxity is present in almost 10 to 15% of chronic ACL deficient knees, and this needs to be addressed. If you do an ACL reconstruction alone in these patients, they will often come to you saying that my knee goes backwards suddenly when I am walking, and this is because of an overlooked PLC. This is a case of an overlooked PCL and a PLC. The ACL was reconstructed, and very often we find that ignoring the PCL can lead to a fixed posterior contracture. And in these patients, when you want to do any kind of surgery, you need to get the PCL, the posterior capsular contracture, corrected. Re-injury can occur in the early phases of rehab before the ligamentization process takes place, where you can do aggressive rehab and damage the graft, or you could have re-injury after the patient has been completely rehabbed. Much less is known about the biological failure of ACLs, but we know for sure that when patients have RSD, they have recurrent synovitis, the chances of biological failure are extremely high. Not all patients who come to us with a failed ACL need surgery. Those who are less active individuals, who have significant arthrosis, who have axial malalignment, are patients who may be managed non-surgically till they are ready for any kind of definitive procedure. Surgical management should be advised for people who have symptomatic instability during activities of daily living or sports, and not predominantly because of pain. So when you do a pre-operative assessment of anyone with a failed ACL, you need to find out that the patient's complaints are instability and not pain, because pain will not go away by doing a revision ACL. When you plan surgery for a failed ACL, you can do either a revision ACL alone if there are no other associated laxities. But as Andy said earlier, probably you need to do an intra plus an extra articular reinforcement in all these patients. You need to address all the associated lesions. In patients who have axial malalignments, it is always better to do an corrective osteotomy before doing a revision ACL. And then you need to decide whether you want to do a single or a staged procedure. For revision ACLs, one must do a proper pre-operative planning. You have to have a plan for intraoperative management of all the surprises that you might get, and you have to do a proper post-op rehab to get favorable outcomes. So what do you want to know before you even start or plan an revision ACL? Why did it fail? What is the present condition of the knee? Is it arthritic? What graft was used? What implants were used? What is the tunnel position and enlargement? What is the condition of the bone? Is there osteopenia or RSD? Because you don't want to proceed with a revision in these patients. Is there any evidence of low-grade sepsis? And what are the missed pathologies, and are there any alignment issues and arthrosis? It's very important to sit down and have a detailed history to find out from the operative notes of the previous surgeon where there were any intraoperative mishaps, what were the fixation methods used, associated pathologies, whether they were repaired or resected, and rehab protocol. It's very important to tell patients that expectations from a revision ACL should be tempered. During examination, one must look at the entire extremity, look at core stability, look at the muscle wasting, gait, alignment, thrust, and range of motion. Imaging is extremely important. Plain X-rays can give you the position of the implants, tunnel positioning, tunnel widening, impingement, alignment, and joint space and arthrosis. A Rosenberg's view helps you in finding out early arthrosis and joint space narrowing. In some cases, you may do a stress view to find out the cause of failure and associated laxities. In most patients with who have to undergo ACL, we will normally do a scanogram to make sure that the alignments are okay. An MRI is useful, but sometimes may not be adequate in the presence of different implants. We routinely do a 3D CT scan in all our patients to find out tunnel widening, and then you have a radiological classification of about the type of failure: type 1, type 2 where the tibial tunnel is enlarged, type 3 where you have enlargement of both the tibial and femoral tunnels, and type 4 where you have enlargement along with associated instabilities. So this is just to show you the same type 1, 2, 3, 4, and this helps you to plan whether you want to do a stage procedure or a single stage revision. Stage procedure is preferred when patients have joint motion deficits, there are widening of tunnels. You want to, if you are excising a synthetic ligament and then doing a revision, we always prefer to do a stage procedure because you don't want synovitis following residue from the synthetic implant. And if there is malalignment, we always prefer to do an osteotomy before planning a revision, and this is always done in a stage procedure. So this is a synthetic graft which is being removed. This is another patient where we planned a 2-stage because of the tunnel enlargement on the tibial side. This was the removal of the screw and packing of the bone graft. A widened tunnel 6 months after grafting. This is how you can get before you plan your revision ACL. You can pack both your tibial or femoral tunnels, or in some cases you can use a bone patellar tendon bone with wider bone plugs to fill these bone defects and do a first stage ACL reconstruction. Hardware issues can be a problem during revision. Fixation devices that do not hamper your tunneling may be left alone. Those likely to compromise results have to be removed, and you must have special instruments to tackle all these hardware that is in place. If it is a type 1 failure where the tunnels are completely wrong, and this is what we see in majority of our patients, doing a revision is as good as doing a primary ACL reconstruction, because most often we find that tunnels are completely wrong both on the tibial and femoral sides. And therefore, revision ACL in our setup is really not been very challenging. But it is only when you have patients who come with tunnels in the right position who have failures that you really can have challenges where you have to do bone grafting and figure out how you are going to place your newer tunnels. And for that you may have to place your femoral tunnel maybe by using an outside in jig. You may have to play around with your tibial tunnels by altering the angle of the jig and moving it in the coronal as well as the sagittal planes. So tibial tunnel alteration is also can be done. Various graft options. Now, since most of us have access only to autografts, I think that is a big challenge before us, how to use our graft judiciously to do a reconstruction. So these are the various options. For a failed patellar tendon, you can use the hamstrings. For the hamstrings, you can use the patellar tendon. You can always go to the contralateral side. The quadriceps tendon has found increasing popularity in recent years, and that is an extremely good option. Recently, we have gone to use of allografts, and we have just done one case using allografts from the Ramaya Medical College, and we are very happy with the quality of the grafts that we got. One should be aware of various surprises that one can encounter during revision surgery. You could have PMC laxity, ramp lesions, popliteus tendon injuries, and these need to be addressed. One must be conversant with the various extra articular procedures that may have to be done at the time of revision ACL. You should have all kinds of fixation devices. Rehab should be properly planned. One must remember that revision ACL is more or less like a salvage procedure. The results are usually not as good as a primary ACL. Most patients would improve functionally, but return to competitive sports is unpredictable. Even bigger challenges today are revising a failed double bundled reconstruction and revising a failed bilateral ACL reconstruction. So these are even more. So this is a failed double bundled reconstruction in the short, fat female, and you really do not have any kind of, you have real challenge of procuring grafts for this kind of patient. You can see that not only does she have AP, but she has significant mediolateral instability as well. So key requirements for revision are patient's expectation should be tempered. The surgeon should be well versed with revision surgeries with all the intricate technicalities that are associated with it. Appropriate surgical backup should be available, and one should plan pre-operatively, intraoperatively and post-operatively for better results. Thank you very much.
Thank you, Dr. Anant.